Hi everyone. Good afternoon. So welcome back once again with newer video. Due to some of mishappening, I was taking a break for recording the videos. So I have got one of the information that one of the webinar has been scheduled by Center for Nutrition Studies, Poya, named to be university, that is from Karnataka. But due to some of the mishappening in my family, I have forgotten. Likewise, I have not got the time to upload this video. So actually, that webinar is directly on that newer clinical trial registry that new studies came. Later, you might be knowing about this the Russian trial studies in India that is directly interlinked with tuberculosis. The Russian still stand for reducing activation of tuberculosis by improvement of nutritional status. So that session has been concluded yesterday. I was also over there that on based on that and the research paper which has been published in the Lancet. So we will be discussing on that only that how to overcome this burden of tuberculosis by the involvement of new strategies in the nutritional background supports on this. So let's start on this. So the summary of this, the Russian study is like basically it's directly a cluster and RCT has been done that the geography has been selected for Jharkhand, and we will discuss detail about that the four district which has been where this study has been done. So directly they are providing nutritional support to the household contact of adult patient that who is biologically confirmed tuberculosis patient. Uh, to evaluate the nutritional background support on tuberculosis to reduce their mortality as well as to increase their treatment success and outcome within the Russian patient cohort. When you will go through that TBC India report, that in the last 3 years report, when you will go through that, then you will come to know about there is a lot of things that intervention is going on, treatment is going on, but the thing is key success is coming. Like basically, the data is not up to mark that which we are planning as per NHP. Uh, so, so that's why this intervention has been done to directly support on nutritional background to overcome these burden and to reduce the mortality as well as uh, morbidity as well. So, in short, that methods which has been involved, like which we have discussed, that RCT study has been like this randomized clinical trial has been utilized for this, and the patient enrollment is like basically 2,800 patient has to be enrolled in these studies who are microbiologically confirmed pulmonary tuberculosis and nutritional support that which has to be provided, that nutritional kit has to be provided, that which will be having 1200 kilocalorie, apart from this 52-gram protein per day, apart from this one micronutrient pill and that will be continued for 6 months. uh, and if the patient is MDR, lying under the category of MDR, then the support, nutritional support, and these 52 gram protein plus micronutrient pill will be continued for 12 months. Apart from this, recorded likewise ki BMI has been recorded, diabetes mellitus status has been changed, and performance status has been changed as in baseline. So after the completion of this intervention, that can be matched with the baseline, that what is the expected changes is coming from baseline and line. So the clinical outcome which has been came under this treatment success, tuberculosis mortality, loss to follow up, change in performance status, weight gain recorded in 6 months. So analysis of predictor for the tuberculosis mortality has been done by using Poisson and Cox regression. We will discuss that as well. So the finding shows that this is just a brief overview is in the starting of this 8 minute, that which we are concluding on the behalf of likewise writing the abstract. So this will be just overview, and after that, if you want to go through the complete study, complete. knowledge over here, complete update on this clinical trial, so you can conclude till end. So the finding is that 82.4% of patients were underweight at the enrollment, and so the treatment success has been achieved like basically 93.7%. Tuberculosis death has been reduced to 3.9%, and loss to follow-up was very low, 1%, 0.2 treatment failure during 6 months of follow-up. So this is just a written part over here. When you will compare this Russian studies with the like basically this is done in only in the Jharkhand wala region, at the four district. When you will go through that TBC India report, then you will come to know about that key there is a lot of fluctuation in treatment success and tuberculosis death and loss to follow up. So a lot of things is needed to work over there to achieve the sustainable development goal which has been fixed. Apart from this, which has been proposed in NHP protocol as well. So medium weight gain is 4.6 kg, and while 54% has been remained underweight. So, a predictor of tuberculosis mortality, baseline weight, BMI, poor performance status, diabetes, and hemoglobin, which has been discussed in previous as well. That we will be going to do this Poisson Cox model to analyze their deaths. 5% weight gain at 2 month associated with hazard to the death. So 5% was weight gain at 2 months is directly associated with this hazardous deaths, which is over here. Interpretation, nutritional support, particularly in sitting with a high prevalence of severe undernutrition, is associated with improved treatment outcome. Likewise, when we are going to directly intervene, intervention will be going to be done through that nutritional support, which has been done in this rational studies. So this shows that treatment outcome will obviously it will going to be improved over there. Early weight gain within the first 2 months significantly decrease the hazard of tuberculosis mortality. Likewise, their mortality has been reduced because of this nutritional support. The weight is getting gained, and so on this physical activity will be also will be going indirectly to be increased. So this way we can reduce the mortality. Nutritional support should be integrated into patient-centered care for enhancement treatment outcome in similar studies. So it has been proposed in the behalf of this study that patient-centered care we are doing likewise a regular visit is been going to be done to visit their tuberculosis patient, either it is PB or and that MDR if it's coming. So in this case, we can directly intervene through that nutritional support as well by having this patient-centered care. Likewise, the objective for this. Before going through any of the study, so scientifically, we will go through that search about that if any study has been done directly on this, supporting on this or not. So for that, a recommendation has been done that everyone is going through a systematic review and to assess that systematic review or meta analysis that to assess that number of research has been done on directly proposed on this topic. So before this Russian studies, evidence has been collected and the search strategy, likewise, is searched in the Medline Cochrane Central Registry of Control Trial, as well as Cochrane database for SR until that last date has been taken until 15 November 2022. While search term has been taken that macronutrient, micronutrient, food supplement, diet supplement, nutrient support, and nutritional supplement. So inclusion criteria has been selected that since 1952 data has been taken that English publication till August 2019. Observational studies has been included, clinical trial has been included, and key review article also has been included in this. So the finding with this shows that macronutrient supplementation effect on tuberculosis outcome with incongruence due to few small trial unable to achieve optimal calorie and protein intake. So it was a small trial. So on that background, optimal calorie and protein intake has been not uh, concluded likewise he calculated in that in that optimal likewise key um, sample size. So that's why it's not going well. A relative risk of tuberculosis mortality in four trial. Likewise, when we are going through the meta, so we are going to club that all the participants. So in the four clinical trial, 67 participants suggested the potentially effective intervention. So effective intervention to reduce, likewise, to reduce that mortality. Ethical challenges in conducting RCT in setting like India with prevalent severe undernutrition and food insecurity. So a lot of challenges is over there, likewise hard to reach area and apart from this, already likewise prevailing severe undernutrition uh, as well as food insecurity. So a lot of challenges over there. So on that background, this likewise these studies are very low. Added likewise another values for this study uniqueness is that largest programmatic cohort on mainly HIV negative and drug susceptible tuberculosis patient undergoing comprehensive evaluation of clinical nutrition performance status. So this is showing that added value of this study that which Russian studies. So this is the largest programmatic cohort which is going to be involved at HIV negative drug DSTB as well as DRTB and nutritional and performance studies is also going to be checked. Focus likewise documents the effect of food ration based nutritional intervention on clinical and nutritional outcome. So the key findings shows that a high level of severe undernutrition and diagnosis contribution to tuberculosis mortality. Likewise, the nutrition undernutrition part is very much the likewise undernutrition is responsible for causing a maximum deaths of tuberculosis. So that's why some of the nutritional background support has to be strategized and intervened. 80% of deaths occurred at home within the first 2 months. Predictors of death, likewise, indicator which is causing death, performance status, nutritional status, hemoglobin, and diabetes. So, nutritional support shows that survival is getting to be increased in the 85% who are even under vital and nutrition. So this is the findings, and 61% reduced hazard of death with desirable weight gain. So when weight is going to be gained, and so these type of deaths is getting to be prevented. Case fatality ratio lower than in a similar cohort without nutritional support. Well acceptable nutritional intervention associated with high treatment adherence and low treatment failure rate. Likewise, the most issue which I am again and again saying that given you will go through that report of TBC India, so even if the recent one 2023 has came on the World Tuberculosis Day has been launched in the Varanasi. So when you will go through that then you will come to know about treatment adherence is low and failure rate is very high. So when you are going to do the intervention through the nutritional support, then these will be going to be reduced, and we will be going to achieve that high treatment adherence and low treatment failure rate. Nutritional recovery incomplete at 6 months in severely undernutrition patient at enrollment. So which has been incomplete in the 6 months. So who are undernourished patient at the enrollment. Well, likewise, now the Russian study is going to be we're going to be discussed. So before going on that directly on rational studies, so we should know about that key TV burden in India. So the reference is the Lancet, and I will provide that in the last slide as well as in the description as well. So I have collected from one of the paper which has been published on the rational clinical trial in the Lancet on the paper. So this paper has been likewise recorded that India faced 3 million TB cases and 4,94,000 TB deaths among HIV negative individuals in 2021. So this has been reported. If you need further reference, so you can check out the reference. While national strategic plan aim for an 80% of reduction in TB incidence and 90% reduction in TB mortality by 2025 as compared to the data of 2015. So, impact of COVID-19, while this is directly interlinked with this Russian studies, when the like basically enrollment of patient has been done. So at that time, it was with tuberculosis. Likewise, it was that a part of COVID era. So doing the nutritional support as well as this is hard to reach areas. So they have faced the challenges. So that has been got affected by this COVID-19 pandemic. Challenges was the likewise key is it's still prevailing that early diagnosis of tuberculosis is still quite a loss. It's a big challenge for us, and quality care is also a challenge. While management of comorbidity, likewise HIV, apart from this diabetes, apart from this hypertension, along with tuberculosis, so are essential to prevent TB mortality. So, likewise, we have discussed that common comorbidity. Undernutrition is frequent comorbidity in TB patients in high burden countries like India. So, India is likewise the very likewise I am not a lot of patients of tuberculosis has been recorded from the part of India only. So, and as well as undernutrition is playing a lot of frequent comorbidity for TB patient in this era. So, severity, TB related weight loss, likewise, which was one of the symptoms, pre-existing chronic undernutrition, and often severe persistence of, after treatment. So, as weight loss is one of the symptoms with it, and if the patient is already previously undernourished, previous to getting the infection, and so that is going to persist while the duration of treatment as well. So that creates a panic situation and fall the patient into the category of severity, which will lead to be like basically anything will be going to happen. So a lot of death is coming from these regions. Undernutrition is consistent risk factor for mortality, drug toxicity, and delayed sputum conversion, as well as reoccurrence of tuberculosis. While on the other hand, WHO recommendation, like the WHO guideline, recommend nutritional assessment, counseling, and support as an integral to TB care. So, a nutritional assessment should be over there, counseling for the TB patient, like this for the treatment, for the nutrition, for other activities like this, drinking activities, as well as smoking activities, cleanliness, hygiene maintenance. So that the part is needed, is has been recommended by WHO guidance. Implementation status likewise ki, um, a nutritional assessment as well as the nutritional support is it to be widely adopted in national programs so that we can reduce this mortality and morbidity and we can achieve our goals which has been proposed by NSP as well as SDG. Modeling studies indicate that addressing undernutrition could reduce TB mortality. So this is also one of the studies which has been recommending this to how to reduce the TB mortality. It's also suggesting that we have to do the intervention through like this nutrition support. In clinical trial, so in conclusive evidence that the impact of macro and micro nutrient supplementation is also showing over there. So the Russian trial aiming at nutrition support. So the objective for this ration is that focuses on household contact of TB patient in Jharkhand, India. So primary objective estimate the effect of nutritional support on reducing TB incidence among household contact. So, likewise, if one of the TB patient has been identified, so its objective is to uh, reduce the TB incidence in the household context. So, if one of the patient is get infected with the tuberculosis, so the first and foremost, he or she is going to infect that the very close to that person, and that comes to the context of household only. So the enrollment period has been taken for this is starting from 16 August 2019 to 31st January 2021. Patient cohort 2,800 patient with microbiologically confirmed with pulmonary tuberculosis. Nutritional support provided in the form of food ration and micronutrient pill. Duration which has to be provided the nutritional support for 6 months, followed by if MDR patient is over there, then 12 months. Baseline assessment, which has to be done previous start of this study, is BMI, diabetes status, and performance status. So, outcome at 6 months shows that 93.7% patients shows a success in the treatment. TB deaths has been declined to the 3.9% of the patient. Loss to follow, 1% has only shown that falling the category of loss to follow. On the other hand, treatment failure, 0.2 patient only shows that. Uh, Median weight gain 4.6 kgs median weight gain has been achieved throughout this in all the enrolled patients. Underweight patients still remain likewise 54.8%. Predictors has been already discussed. Associated with weight gain, 5% weight gain at 2 months linked to reduce as deaths of these patients. Well, a recommendation is that a high under nutritional level. Uh, the study highlights severe and extremely severe undernutrition in TB patient at diagnosis, a contributor to unaddressed TB mortality. Predictors of death, which again we are discussing, performance status, nutritional status, hemoglobin and diabetes identified as predictors. Survival and nutritional support. 85% survival in patient with potentially fatal undernutrition emphasizes the role of nutritional support, which giving the implies the highlights on nutritional support to reduce this mortality. CFR lower in patient with nutritional support compared to the similar cohort who is not having the nutritional support. Intervention acceptance. Nutritional intervention well accepted with high adherence to treatment and low treatment failure rate. So nutritional intervention is very highly acceptable, which is putting result in the form of low treatment failure rate. Incomplete recovery. Nutritional recovery incomplete at 6 months in severely undernutrition patient at enrollment. Recommendations: implement nutritional assessment, counseling, and support in high TB and undernutrition burden settings like India for improved treatment outcome. Food-based nutritional support during treatment is associated with positive income. So this is again it's recommending our studies of this Russian study with positive outcome. Although recovery in severely undernourished patient may require prolonged credit support. So the methodology which has been used in this. So before going in deep with the methodology, as we have discussed this TP in aspect of India, so we should also know about TP in aspect of Jharkhand, where we are going to implement our ration studies. Were implemented. Sorry. Tuberculosis case notification rate is 130 per lakh population. Prevalence of microbiologically confirmed pulmonary tuberculosis 352 per lakh population when you are comparing with the national average of 316. So it shows that it is high in the Jharkhand from the national level, national average as well. The Russian trial was embedded within the NTEP in the four districts of Jharkhand. So, like with West Singhbhum, East Singhbhum, Ranchi, as well as Saraikela, Kharsawa. Jharkhand has substantial forest cover, predominantly rural population is 75%, and a significant indigenous population makes one reach 25. The state faces multidimensional poverty. 46% of population and high prevalence rate of underweight in women, that is 26.2%, and children under 5 years, 39.4% compared to the national average. So if you need the reference, so reference will be provided in the last of this presentation as well as in the description. So you can go and like we say, you can go through that all the references to get more detailed information. So as the study design is CRT has been used, clustered randomized control trial. So detailed method, recruitment, intervention, and outcome has been also like previously we have discussed. The trial population comprises household contact of 2,800 patients with microbiologically confirmed pulmonary tuberculosis. While cluster randomized control trial, 28 trial cluster tuberculosis unit were randomly assessed in 1:1 ratio. Intervention group received the nutritional support like as food basket micronutrient for household content. Control group received no nutritional support for household contents. So the primary outcome difference in tuberculosis incidence among household contact over a 2-year follow-up from the treatment of the index patient with microbiologically confirmed pulmonary tuberculosis. So this follow-up will be done for the 2 year. So for the household of index patient is microbiologically confirmed tuberculosis. Secondary treatment outcome followed up for the treatment period for the secondary outcome including tuberculosis mortality, all cause mortality during treatment, treatment success, change in nutritional and performance status, and occurrence of severely adverse effect, if any is there. While nutritional support for all patients, regardless of baseline nutrition status or assignment group, all 2,800 patients with microbiologically confirmed pulmonary tuberculosis received nutritional support, food basket, and micronutrient during the treatment period. Eligibility criteria for the enrollment likewise keep patient aged 18 years or older with microbiologically confirmed pulmonary tuberculosis. Initiated on treatment within the previous 2 week. Eligible household contacts were person living in the same house as an index patient, sharing the same kitchen for at least one night or for frequent or extended period during the day during the 3 months before the diagnosis of index patient. So these are the eligible household contact. These all will fall under the eligible household contact. Household contact were ineligible if currently on treatment for microbiologically confirmed or clinically diagnosed active tuberculosis. So these will be ineligible. Ethical approval has been already taken for this Russian studies by ICMR and IRT. Local oversight in Jharkhand has been provided by AGJUD. Written informed consent has been taken from all the participants. While the procedure is monthly food basket supplying 1200 kilocalorie and 52 gram protein per day and a micronutrient pill has been provided. Delivery of food ration was challenging due to difficult terrain poor connectivity, and complication related to the COVID-19 pandemic as well. An individual patient food ration were extended by up to 6 months if BMI was less than 18.5 at the end of treatment. While monitoring monthly follow-up for 6 months included monitoring symptoms, treatment adherence, consumption of food rations, adverse drug reaction, anthropometry, and ECOG performance status. Mortality and adverse drug reaction reported to the field staff so that they can go to the nearby facilities to overcome this. Outcome: cure or treatment completion, treatment success, and death during treatment will be going to be decreased. Loss to follow, as it has been shown in the previous data, it has been decreased. Treatment failure is also reduced. Minor adverse drug during treatment has been reported, but less. Tuberculosis mortality, all-cause mortality in HIV negative patient during treatment. CFR, likewise, case fatality ratio is defined as a number of patients with tuberculosis mortality divided by the number of patients forming the cohort at the beginning of the observed period. So the outcome is this: कि, when overall we have taken that 2800 2800 sample language and is taken with 2800 that total patient has to be enrolled in this. So the male total male and female. So the male is that ki 70% male is getting underweight and mm, in this, and the female is 821, that is 29.3%. So the details is we can discuss that as well in the later also. These details has been given over here. So if you want to go through this underweight, not underweight, is specific on the behalf of sex, age, as well as caste, like we see caste coming underweight, not underweight, so SC, ST, and other background, and the educational status who are coming underweight as per the BMI and not coming underweight. So the history of alcohol use in the category of underweight, history of tobacco use. So directly this all the data has been given over here as well as and the same is given in the reference which I will be sharing. So the detail is and the history of previously tuberculosis in family member. So again, that the same category is running underweight or not in underweight. HIV, diabetes, MDR. So demographic and body weight, likewise this. So body weight category and height is coming over here. So it's directly that is taken under the that is in form of kg and directly it's in the term of men and women. So when you will go through the men, then the ratio is higher, that is coming to 42. And body weight category is directly in the age group category has been also taken. If you want to go through that 18 to 24, while 25 to 29 it's only 172. Yeah. So these all are the details. While on the other hand, if you want to go to the height, is stunting as well in the category of men and women. Overview of patient life basically this age we have taken over here, age and height. So demographic mean age for men it's coming 41.5. On the other hand, for the women it's coming 37.3. So, socio-demographic characteristic predominantly indigenous community, manual labor, beneficiary and subsidized food. Baseline characteristics shows that ki body weight mean 42.6%, 6 kg, for men, 36.1 for women, and 80% underweight. While on the BMI, mean is 16.4 for men and 16.2 for women. Majority severely underweight. Health condition 0.3% HIV tuberculosis co-infection and 5% diabetes. Clinical characteristic 1% overweight or obese has been found out, 93.7% success in treatment. Adverse reaction shows that joint pain in 45%, loss of appetite resulted in 21%, itching reported in 18.6%. Deaths total death has been taken place 108, which follows on 3.9% of CFR. Survival analysis overall incidence of tuberculosis mortality 8 per 100%, while median time of death is 46 days, 54% of deaths in the first 2 months. Factor associated with higher mortality, poor performance status, low body weight, and low BMI. Nutritional support and outcome, weight gain, median gain of 4.6 kg in 6 months, higher weight gain in men. BMI increases from 16.4, which has been recorded in the baseline, to 18.4. 54.8% is still underweight. ECOG performance improved from 2.8 to 75.4% in prognosis factor for tuberculosis mortality, diabetes, poor performance status, lower baseline body weight and BMI. Weight gain and survival in prognosis, likewise a higher weight gain associated with lower mortality. So this is the prognosis factor for this. While the last, likewise, under the discussion part is strength for this largest patient in cohort studies, real world implementation, low loss to follow up, and few missing values has been resulted in this. Implication, feasibility, and effectiveness of food based nutritional support despite challenging conditions. Routine assessment. National programs should routinely assess nutritional status, hemoglobin, and performance status. Graded nutritional support. Implement graded nutritional support as a part of patient-centered care. Supervision. Close supervision with the option of referral for inpatient care in the intensive phase. Implication, address undernutrition in tuberculosis patient for improved outcome. So, this overview has been covered already, and the reference is given over here, and I will be sharing that as well in the description part with the detail of um, likewise it's one of the protocol paper. Apart from this, its registration in CTRI as well as some of other details will be provided if you need. And with this, I'm here to conclude this one. We'll meet you in the next video as soon as possible.